of cardiovascular pathology. Hi students, this is Jamie. I just wanted to make a podcast on this section of cardiovascular pathologies. I wanted to highlight a few of them for you and kind of talk about how they apply to you as the PTA. Sometimes I think when you're reading this chapter, it talks about cardiac arrest and that you should do CPR and what are the signs of shock and what should you do when a patient has angina? What are the warning signs of a heart attack? What's the emergency treatment for someone with angina? And I want to go over those things too, but I kind of wanted to give you the personal perspective of how you may see these patients in the clinic or in a skilled nursing facility or in a hospital acute care setting. So remember, when you're looking at this chapter and you're reading about angina and what it is, and basically angina is an acute ischemic chest pain. It's caused by ischemia to the heart or the myocardium, and it's related to heart disease. So this patient has heart disease, they've got plaque. This is a type of a sudden chest pain. And so you may not be obviously seeing a patient for physical therapy because of angina. You might be seeing a patient for another reason. Maybe they've had a knee replacement, a total hip. Maybe they just have a torn rotator cuff and they're coming to you in outpatient. So I want you to think about there could be an underlying condition of angina that you don't know about, or that this isn't your primary diagnosis. And I think this is probably something that does come up in physical therapy if you're working with a very good physical therapist and they've done a PT eval that is thorough, they've done a patient history. They will have asked the patient if they have any heart problems or heart diseases or disorders, and the patient will have come forward and said, well, yes, I have angina. So that may be on the PT eval to kind of clue you in. The thing about angina is that it's a pain that tends to be very severe, very sharp, and it comes on very suddenly with overexertion, emotional stress, or extreme exposures to temperatures or high humidity. And so when you think about physical therapy, we're doing just that. We're causing exertion. We're having them perform exercises for us. Maybe they're in bed and they've been in the hospital and they've for some reason they have another diagnosis and they're in their hospital, and you have to get them up to do bed mobility or assist them with a transfer. Well, they've been down in the bed for a while, so just moving in bed and doing a transfer is exertion and could bring on an angina attack. The pain for the patient can either be felt in the upper chest, or the referred pain could be in the neck and the shoulder and the left arm. People may live for many years with angina. It's something that patients deal with. If the condition becomes so severe, heart bypass surgery may be performed. In some cases, angina can lead to a heart attack, but is not usually a direct cause of death. So angina doesn't cause death. It's the heart attack, right? It's the heart disease. It's the plaque that builds up that can throw a clot. When you work with a patient who has angina, who's been diagnosed with angina, they usually carry around nitroglycerin with them. And this kind of falls under the medical intervention there. The patient would use a nitroglycerin. Nitroglycerin is a vasodilator. So basically it comes in two forms. It comes in a tablet form that a patient puts underneath their tongue, and it's quickly desorbed into the bloodstream. It's a vasodilator, so it opens up all the vessels, allows for more blood movement, allows for more oxygen. It can also be, patients can wear it as a patch, a medication patch that's worn either on the stomach or down in the glute region, and this is a patch that's continually putting an amount of nitroglycerin in the body through the medication patch. And the patch is slow acting versus the nitroglycerin, a patient with those with them, if they feel an angina attack coming on, if they feel a type of pain in the chest and the discomfort, they can take a tablet and put it underneath their tongue. Now remember, as a PT or a PTA, you're not allowed to administer medications. But let's say you're in an outpatient clinic and the patient is in there for a torn rotator cuff, and then you're doing exercise with them and all of a sudden they start to have chest pain. And they say, I have angina. You can ask the patient, do you have nitroglycerin with you? If they have that with them, then you can advise them to take one, and at the same time, you're calling 911 or you're having someone else call 911. And if the patient takes nitroglycerin and it doesn't work, they can take another one in about 3 minutes. A general rule is that if the pain is not relieved with a third pill, that the patient needs to seek medical help immediately. In this situation, when you're in the clinic, the patient has chest pain, you just want to right away call 911. You don't want to wait. Let's see, so what else can I tell you about angina? So physical therapy is not usually indicated for patients with angina because many patients have this condition. So it goes along with what I was saying with maybe they're in to see you for something else and they just happen to have angina. And that's why it's important for the PT to do a thorough evaluation and a history for you as you're working with a patient. I'm trying to see here if there's anything else that I wanted to really kind of hit on from your book, but I think that's pretty much, your book talks about some emergency treatment for angina. Let the patient rest, stop activity, obviously, seat patient in an upright position, have the patient use the nitroglycerin if they have that. You can check the patient's pulse and respiration. If you have oxygen, you could administer oxygen. If you're in an acute care setting, you're gonna get the nurse with this chest pain. So that pretty much makes sense, right, of what angina is. The next one is an MI, or a heart attack, and let's talk about that a little bit. Cardiac arrest, or an MI, can be a result of various factors. So the heart stopping could be because of a loss of blood to the heart, secondary to a systemic shock or injury causing massive blood loss. Could be a traumatic event such as an electrical shock or drowning. There also could be the predisposition to MI, includes factors such as heredity, age, obesity, smoking, hypertension, diabetes, a sedentary lifestyle, and high cholesterol and high triglyceride levels. The signs and symptoms, the main area of the heart involved in the MI is the left ventricle. Some signs and symptoms may indicate an impending MI, but in many cases there are no warning. In some cases there will be signs such as difficulty breathing. They may have angina, which is the chest pain we just talked about. They could have a rapid heartbeat, tachycardia of more than 100 beats per minute. In most cases the onset is sudden, with symptoms of the tachycardia. Excuse me. They can also have bradycardia when the respiratory system is starting to shut down. There's no breathing is possible. They have pain in the chest. They can describe it as also in their neck or in their left arm. It can be described as a crushing pain. They can be sweating. They can be white. They can be nauseated. They can have a rapid pulse. They can have a loss of consciousness. Heart attacks. What can I say as a heart attack as a PTA? Well, I can tell you a story. I can tell you a story that's one of those stories that I'll never forget as a therapist. I hadn't been a PTA for very long, and I was working in a skilled nursing facility, and this gentleman that I was working with was adorable. I still remember the first time I went in to do therapy with him. He'd had quadruple bypass. He had heart disease. He had had so many operations on his heart, and he actually had gotten pneumonia, and he had gotten very debilitated in the hospital. He couldn't quite go home because he had a number of stairs. And so he came to the skilled nursing facility, and I was treating him. And I remember the first day I went in to see him, and I walked in the room, and there was no one in the bed, but there was this gentleman dressed with a top hat on and suspenders sitting in the chair. And I thought that my patient must be in the bathroom or not there, and he said, "No, that's me." And he was just a wonderful man, and he was so fun to work with, and that was him. So every day he got up and he got dressed, and he said, "I'm not going to lay around here in a hospital bed." So he would always be ready for therapy, and I had seen him for about 3 weeks, and I had watched him progress. He was very debilitated. He was very weak. He would get very short of breath. We would walk from his chair in his room to the door, rest, which was only about 20 feet, and then go back. It was a series of trying to regain his endurance. And we had even progressed to walking outside into different surfaces. And I'll never forget it. I saw him twice a day, once in the morning, once in the afternoon. Obviously, this was before healthcare as it is today, but we walked outside together, and we sat on a bench, and he was resting, and he was very out of breath, and he was disappointed in his abilities and the things that he couldn't do. And he looked at me, and he said, "If this is the way, my life's going to be, I don't want to be here anymore." And I remember talking to him through that, and we were talking about all the positives and the goals that he has reached and how he has improved. And it made him feel better, and then we went back into his room, and then that afternoon I went to do therapy with him again. And as usual, I arrived after lunch, and he was sitting in his chair ready to go. And he stood up, and he walked about 3-4 feet, and we were talking, and all of a sudden he got very quiet, too quiet. And I looked at him, and I knew immediately something was desperately wrong. He was pale, he was sweating, and I said, "Are you all right?" And he didn't speak, and he just grabbed his chest, and he was collapsing. And so I grabbed him. It's one of those moments that you have adrenaline and you just, have super strength. But somehow I grabbed him and I got him in the chair, and he was having big difficulty breathing. And then all of a sudden he stopped breathing. And I ran out in the hall and screamed for help. And the nurse came in. And as the nurse is coming in, I'm feeling for a pulse, and there's nothing. There's no pulse. So we pick him up and we lay him on the ground, and I'm ready to do CPR. I have a what's the word I'm looking for? I was a paid firefighter, EMT. That's where I went after high school. It's what I did before I went to be a PTA. And so I whipped out his dentures, and I was so ready to do CPR on him. And the nurse said, "He's a DNR. He's a do not resuscitate. You cannot." And it was the hardest thing I've ever done, because in my emergency care, this is where I do my best work. This is where I would bring people back to life. And I really had a hard time. I really wanted to start CPR, and as you'll know, when you go through ethics, if you start CPR, you can't stop. And the nurse had to actually bring me his DNR, because I was so worked up. I just so wanted to start CPR. And of course, he was a do not, and I had to respect that. And at this time, he still doesn't have a pulse, but he's agonal breathing, which is kind of periods of where there's some breath and then there's some stop, and then there's a breath and there's stop, but they're not really breathing. And all I could do was hold him in my arms and watch him die. And it was the hardest, it still is the hardest, after everything I saw in emergency medicine as a firefighter and everything I've done in my 20 years as a PTA, it was just the hardest moment to let your patient die. And I think that I tell you this story not to scare you, but it can happen. You know, patients that you're working with, some of them are very sick and they're very ill, and you know, there wasn't anything I did that caused him to have a heart attack. He had a bad heart. And you may be working with someone, but I think the key to when you're reading this chapter and you're learning about cardiac arrest is seeing the signs. So for this gentleman, I mean, he had a massive heart attack. I mean, there isn't anything that could have been done. But maybe you're working with a patient who they don't all of a sudden have a cardiac arrest. Maybe they start telling you, you know, John, I don't feel good. You know, I want to do therapy with you, but I'm having some pain right here in my chest. I kind of feel some pain in my arm. I feel some jaw pain. I don't feel right. I have an impending, I feel like something's wrong. Okay, you need to do something about that as a PTA. You need to take notice. You can't just say, you're doing fine, you're going to be all right. No, you need to sit the patient down. You need to get the pulse ox. You need to monitor their vital signs. You need to see what's going on and maybe get a nurse, because sometimes there can be warning signs. And I tell you this story because I don't want you to miss the warning signs. And of course your book talks about the medical intervention for cardiac arrest, which is of course CPR, and getting a fast response. Different places that you work at will have different protocols. If you're a PTA and you're working in an acute care hospital, there's a code blue button on the wall that you push that will alert people to come in and help you. But don't be afraid to ask for help. So if you're working with a patient who's having the signs and symptoms of a heart attack, get some help. Don't wait. Get some help. The interesting thing, not the interesting thing, but the hard thing about this, when this man died in my arms was, you know, you get traumatized by it, and I was, but yet I didn't work with a very nice boss back then, and she made me finish out my caseload. I remember I had to go see 4 more patients, and it was just like, I don't even remember treating them. I was just so upset inside, but I couldn't show it. And I remember I went home and I couldn't sleep, but then I remembered what he said to me on that bench, that if this is the way my life is going to be, then I don't want to be here anymore. And in some ways it helped me kind of get through the emotion of losing a patient. And so you just never know. Cherish those times that you work with those patients. You just never know. Okay, now back to the book and all the important things I'm supposed to tell you about the heart attack. When there is only a small area of the heart recovers more rapidly. A temporary loss of function of the affected heart muscle may occur due to reduced circulation, but then they recover. When a large area of the heart muscle is affected, there are several problems. The central area of the ischemic tissue becomes necrotic almost immediately within the first few hours after a heart attack. The area surrounding the MI is non-functional. Further away from the site of the MI, the muscle contracts very weakly because of the ischemia. Healing of heart tissue is similar to that of skin. The central area of the ischemic tissue dies with enlargement of the necrotic area over the next few days. circulation develops to supply the area of the heart muscle around the necrotic area. And by 3 weeks after an MI, the area around the infarction is either functional or has died. The dead muscle tissue is replaced by fibrous scar tissue, which eventually contract in size over a period of about 1 year. And the rest of the heart hypertrophies to make up for the lost tissue function. The heart recovers either fully or partially. Complications that can occur after a heart attack include cardiac shock, a heart rupture, which basically your book talks about. You can have a heart attack and that piece of dead tissue of the heart can actually break away and cause a hole in the heart. You can also get venous system backup, and sometimes when people are having heart problems, it backs up into the pulmonary system, so they almost have like pneumonia type symptoms. Basically, the lungs begin to fill with fluid. And you can also have, of course, when someone's having a heart attack, different arrhythmias in the heart. Okay, that was kind of long-winded about the heart attack, but I think that I've covered. Your book goes into a lot of different complications from the heart attack, and I'm just kind of summarizing them. You know, the rupture, the congestive heart failure. So that's it. That's the fluid going back up into the lungs. Okay, I think that's about all. Okay, endocarditis. Let's talk about endocarditis a little bit. We're going to talk about the etiology of it, the signs and symptoms, the prognosis and the medical intervention, and also some PT interventions. So endocarditis is a bacterial infection of the lining of the heart, including the heart valves, that can lead to cardiac failure. Endocarditis usually occurs in people who have had prior damage to heart valves or who were born with a heart valve defect. The mitral valve is the most commonly affected. It used to be that a lot of people were walking around really with mitral valve prolapse. So the valve in the heart was not closing all the way. And it didn't until now that there's ultrasounds for the heart and they're done a lot more often, they're finding more patients with mitral valve prolapse. Now, are there more patients with mitral valve prolapse, or is it just because we have better testing now and people are getting diagnosed with it? You kind of have to decide. My guess is it's probably because we have the equipment. It used to be that when someone had mitral valve prolapse, they would have to take antibiotics when they were having any kind of a dental procedure. And the reason for that was because they believed that the bacteria that could get down in a patient's gums from cleaning their teeth or having a dental procedure could quickly go to the valves of the heart, and the mitral valve prolapse, since it's a kind of a leaky valve, it doesn't work very well, it could easily get an infection. And this went on for years. So patients would have to take antibiotics a few hours before they had a dental procedure, then for a couple days afterwards as well. Well, there was enough research that showed that it wasn't actually helping. There wasn't scientific data to back up the need for having patients take antibiotics. So nowadays, patients don't take antibiotics for mitral valve prolapse. Your book talks about that a little bit. But the major cause for endocarditis, either staph or strep. In cases of endocarditis, it can be found in people who are addicted to drugs, because there are many different infectious agents that can happen because of dirty needles. I'm not saying that all endocarditis is caused by drug addiction or needle use, but that is one of the causes. Also, individuals who have immunosuppressed systems are at a risk for getting endocarditis. So that would be someone who maybe has cancer and they're going through chemotherapy, and so the Of course, the chemotherapy is taking away all the good cells along with the bad cells, and so they're at a susceptible risk for infection. And so bacteria can get into the heart on someone who is on chemo from just fungus on their toenails or their fingernails, because their body is working so hard because of the effects of the chemotherapy, that their immune system is suppressed and they're more susceptible to getting an infection, endocarditis of the heart. So those are some possible causes of it. Signs and symptoms. The outward characteristic signs and symptoms of endocarditis include a fever, which may be sudden or slow onset, and it also comes along with weakness. Pathologically, bacteria attach themselves to the valves of the heart, eroding the surface of the valve and causing breakdown of the connective tissue. The roughened tissue then attracts fibrin and platelets deposited from the blood, and projections filled with bacteria grow around the valve. So it's basically pockets of infection, pockets of bacteria. You can see it on that picture there that are around the valves. These valves become inflamed. They can ulcerate, they can deform their shape and stop performing the normal function. The projections that form on the valves can also become broken off and start to circulate in the blood system. These fragments contain bacteria, and when they circulate to the other parts of the body, they can spread infection further. Prognosis. As with many diseases, early diagnosis and medical treatment is the key in a successful outcome. Complications that can occur if the heart valves are damaged include some type of atrial fibrillation, so irregular heart rate. You can get a clot, a thrombus formation. You can have a stroke due to an embolism traveling to the brain. Another complication of endocarditis is renal disease. Other organs, such as the lungs, may be damaged if the embolism becomes ischemic. Treatment for endocarditis is antibiotics. Usually resolves the infection, but heart valves remain deformed and they may have to be replaced surgically. So endocarditis causes damage, so you're not going to reverse that damage that's done by the bacteria, but you can get rid of the bacteria with antibiotics. And just like I said, the use of preventative antibiotics before dental work and certain surgeries were used for people that had a mitral valve prolapse. The people who can be really susceptible to endocarditis are patients who have immunosuppressive. Maybe they're having cancer treatments, some types of cancer treatments, or could be from infection from dirty needles. There are many causes of endocarditis. Basically, physical therapy interventions that we would do, well, we're probably treating the patient so their endocarditis, they've probably been in the hospital, they've probably been down for some time, they're weak, they're probably dehydrated. So physical therapy could be coming in for bed mobility, range of motion, strengthening, transfers, gait. So those are the kinds of things that you may be working with a patient who has endocarditis. All right, congestive heart failure is the next one. Congestive heart failure is something you are going to see with a number of your patients as you work in physical therapy in different settings. Basically, congestive heart failure, the heart is no longer able to pump enough blood to meet the body's needs. There are two types of congestive heart failure. There's the right and the left ventricular failure. Causes of congestive heart failure include a previous MI, could be of heart valve incompetence, hypertension over a long period of time. If someone has a very high or a very low heart rate, can eventually lead to congestive heart failure. Signs and symptoms. Left heart failure results in pulmonary edema, and right ventricular failure results in peripheral edema, evident in the lower legs. Okay, so does that make sense? So if it's a left heart failure, there's pulmonary edema. And if it's a right ventricle failure, then it's peripheral edema, and this is where their legs are swelling. In the right ventricle failure, there is a backup of the venous system causing peripheral edema, and abdominal edema. So when you see a patient who has congestive heart failure, the one thing that's really contraindicated, so you think about it, so their heart can't pump enough fluid. Okay, so they're basically, the heart is being surrounded by fluid, and it can't get it out to the other parts of the body, and so the fluid kind of collects. So the heart's working really hard. I've seen students who've been working with a patient with congestive heart failure, want to elevate their legs, put their legs on a bunch of pillows to try and get the fluid out. Okay, you have to think about that for a second. Their legs aren't swollen because they have a sprained ankle, or because, they're swollen because the heart is working as hard as it can, and it's failing. So when you take someone who has congestive heart failure and you elevate their legs above their heart, you're actually pushing that fluid, more fluid, onto their heart, which is going to cause them an even greater distress of a difficulty breathing. So that's something that's contraindicated. What else can I tell you? Medical intervention. So someone who has congestive heart failure, they're going to work on controlling their diet. They're going to work on exercise. They're going to work on activity. They're going to use an ACE inhibitors, something to control the fluid. They're going to be on a diuretic, something that's going to help them they're basically going to pee out the extra fluid in their body. They're also going to be on some beta blockers. They're going to be on a vasodilator to help open up the vessels so that they can breathe. The beta blockers will help to increase the pumping ability of the heart, and the ACE inhibitors and vasodilators are what's going to help dilate the blood vessel and reduce the resistance that the blood has to flow against, and reducing the pumping effort needed by the heart. The diuretics are, like I say, are going to help the body expel the excess water and salt that's built up in the body that's causing the edema. Physical therapy intervention may be indicated for increasing strength and endurance, as well as gait re-education. Maybe they're going to need some type of an assistive device. It's going to take a lot of work. When you're working with patients who have congestive heart failure, you can see kind of on this picture all the things that are going on with them. These patients will not want you to lay them down flat in the bed after you're done with treatment. These patients like to sit up because they're already having a difficulty time breathing, and if you lay them down, it's just going to make it worse. They'll often be on oxygen. You're going to need to pace them. You're going to be, if you're working with congestive heart failure, you're going to have a pulse ox with you, blood pressure cuff, monitoring their vital signs at all times. Congestive heart failure is one of those things where it's a slow process of rehabbing the patient and getting them back to where they were. You're going to have to really pace them and pace your therapy sessions, giving them rest breaks and helping them slowly to improve. They're not going to improve rapidly. And they're usually on some type of a cardiac monitor as well, so that they're being monitored all the time. They're usually in some type of a telemetry unit. So it's congestive heart failure. Your book talks about just hypertension in general, so I thought I would talk about that a little bit. Sorry, my voice is kind of scratchy. Let's see. Hypertension is a condition in which the normal blood pressure exceeds a certain amount. Hypertension does not take into account the rising of the blood pressure through increased activity levels, which is considered normal when rising from rest. Hypertension can be classified as mild, moderate, or severe. It can also be called essential or primary or secondary. Primary or essential hypertension occurs in 90% of those with hypertension. This means that there is no known cause for this condition. Factors involved may include hereditary, diet, occupation, or lifestyle issues. Some major causes of secondary hypertension, which is due to another disease process, including kidney disease, an adrenal tumor, physiological factors, and some drugs such as painkillers and oral contraceptives can cause hypertension. So, according to the CDC and the American Heart Association, adult hypertension exists when the systolic blood pressure is 140 or greater, or the diastolic blood pressure is 90 or higher. So systolic of 140 or greater, or diastolic of 90 or more. CDC also defines the state of prehypertension as systolic blood pressure between 120 and 139, and the diastolic between 80 and 89. And so those are some of those numbers that you're just going to have to memorize. It's important to memorize those. It's usually a licensure type question of what's considered hypertension and pre-hypertension. Some textbooks may vary those numbers a bit, but those are the ones that that we are going with in the program, because according to the CDC and the American Heart Association. For prognosis, hypertension is a risk factor for many other serious complications such as heart disease, angina, heart failure, eye damage, blindness, and kidney disease. Many people have hypertension are unaware of the fact. Medical intervention, the usual treatment for cases of essential hypertension is, of course, diet modification, antihypertensive drugs, exercise. A rare form of essential hypertension is called malignant hypertension. And this is a type of hypertension that it remains dangerously high. These patients would be put on medication right away. Malignant hypertension is usually a sudden onset. It can cause necrosis of the small arteries, so it's something that needs to be dealt with before there could be damage to other organs in the body. The complication of hypertension is, of course, cardiomegaly, which is the enlargement of the heart. And the effects of hypertension on the body due to the hypertrophy of the left ventricle, which can also lead to just the heart attack, which we've talked about before. Hypertrophy of the left ventricle leads to poor pumping ability of the heart, creating back pressure that increases the pressure in the pulmonary artery and causes the right ventricle to enlarge. Which also, after that right ventricle enlarges to a certain point, there can be failure of that. Although physical therapy is not prescribed for hypertension, the PTA will treat patients with high blood pressure combined with other diagnoses. The importance of checking blood pressure and other vital signs prior, during, and after treatment is extremely important for these patients. Definitely. And the reason, because, just like you see on this picture here, is that high blood pressure could lead to a stroke. You know, when you go in to see a patient in the hospital care setting, you can see the vitals in the chart at all times as they were taken. And you can kind of take a look at what a baseline is on your patient. And then when you go in and see your patient, you could take a baseline blood pressure before you even start treatment, during treatment, and after treatment, if you're working with a patient who has hypertension issues that the physical therapist has actually asked you to monitor while you're doing your treatment. Okay, the next one we're going to talk about is peripheral vascular disease. Peripheral vascular disease, according to your book, peripheral vascular disease refers to any abnormality in the arteries or veins outside of the heart. So these are basically, atherosclerosis, so plaque that gets laid down in the arteries. The most common place is the legs and the abdominal aorta. Total occlusion may result from a thrombus obstructing or breaking off and becoming an embolism and going into smaller vessels in the legs. Sorry. Signs and symptoms: increase in fatigue and weakness in the legs developed as the blood flow decreases. They can have leg pain. Initially, the pain subsides with rest, but as the obstruction advances, pain becomes more severe and may be present at rest as well. Sensory input may decline, and they might have areas of numbness, tingling, burning. Peripheral pulses may become weak or absent. The appearance of the skin of the feet and the legs can have changes. They can be white. They can become blue. The skin can become dry and hairless. The toenails are thick and hard and poorly perfused areas. The feet can feel cold. They can have patches of redness on their feet, so it can be pale and then have like a bright redness that goes down the ankle and into the feet. How they figure out someone has peripheral vascular disease is with a Doppler study. So basically it's an ultrasound looking at the blood flow. It can tell them if there's any occlusions, how the blood flow is going to the feet. Treatment has several aspects, including slowing the progression of the atherosclerosis, maintaining circulation in the legs. Let me just tell you a little bit about kind of what we can do. Physical therapy is mainly related to the complications resulting from it. So we can help with range of motion. We can help with movement of the legs. We can help with teaching the patient how to check their feet. Since they can't feel the skin in the bottom of their feet, they're susceptible for skin breakdown, obviously, even like a wrinkle in a sock, or maybe there's just a small piece of something inside their shoe that they can't feel very well, so this could break down the skin, cause an infection, could go gangrene. They might have to lead to an amputation. Let me see if I can just kind of give you some thoughts of it for the PTA. So the arterial disease results in a lack of oxygen to the tissue involved, and so there can be an direct occlusion, which could lead to gangrene. They could have pain because, of course, of the reduced blood supply to the legs. Patients will be able to walk short distance, but if climbing stairs, if they walk rapidly, they will experience pain, particularly in the posterior lower leg muscles, because the popliteal artery is the most commonly the one affected by peripheral vascular disease. Because the area of tissue involved lacks oxygen supply, it's important that the area not be heated. The arteries are unable to cope with the normal circulation, and if heated, the tissue would become overheated and further damage. Under normal circumstances, the circulation increases to disperse the effects of heat on the tissue. But these arteries are damaged and are unable to respond to the extra demands placed on them. Yeah, you would never take a patient who has peripheral vascular disease and, say, put a hot pack on their legs. You could cause further damage. Massage is also contraindicated because it places too much demand on the arteries. So massage is contraindicated for peripheral vascular disease. Advice to the patient should include ways to minimize the effect of the arterial insufficiency, such as raising the head of the bed when sleeping. This places the patient in a position in which gravity assists the arterial flow to the extremities. If the feet are elevated, gravity would increase the difficulty of blood flow for the arteries in the lower extremities. So, you know, having their head up actually helps the blood flow to the legs. Obviously, if the patient is smoking, the patient would need to stop smoking, keeping their blood pressure under control, having a good diet, taking their medications that are prescribed. teaching them, like I said, about skin inspection, so that they know to inspect their skin regularly for any breakdown. Patients should be warned about not placing their feet or legs too close to a heat surface, such as like maybe a fireplace in the winter, or like a hot bath. They shouldn't get in a hot bath because they can't feel the temperature of the skin of the bath, and they could also damage the arteries, like I was saying. People who have peripheral vascular disease, problems are made worse by constrictive garments. The damaged arteries are unable to cope with the extra pressure from compression, so it's important not to use compression socks with someone who has peripheral vascular disease. I think that is like the main, but of course your book talks about that ulcers could go gangrene, could lead to amputations. I think we've covered all the points there for peripheral vascular disease. Okay, so the DVT, talking about what that is. Let me open my notes to where I had. Okay, so a DVT basically refers to the development of a thrombus in a vein in which inflammation is present. The platelets adhere to the inflamed site and the thrombus develops. The thrombus, the DVT can become dislodged, and so a DVT patient who have a DVT, I think I lost my microphone there for a second. Let me repeat that just in case that cut out. Thrombophlebitis means inflammation and clotting of veins. The condition usually affects either the deep or the superficial veins of the lower extremity. Several causes could be infection, trauma, surgery to the area involved, or long periods of immobility due to illness or prolonged hospitalization, which causes reduced circulation. Yes, so DVTs can be brought on after surgery because the patient is not up and moving. The anti-pneumatic devices that we talked about in 110, they look like, boy, how would you describe them? They're white and they have Velcro on them, and they usually go around the calf and the ankle, and they're a machine that pumps air in and pumps air out, so that it's as if the patient is doing an ankle pump, so it's causing circulation. And of course, patients come out of surgery with these on. The signs and symptoms of a DVT include a fever, a general fever. They can have tenderness in their calf. There can be redness to the area, an actual hardness to the tissues in the area, pain, tightness in the area. Signs of a DVT in the popliteal vessel of the lower leg, which is what we usually see with PTs, in physical therapy, include pain in the central posterior calf, sometimes with swelling, tenderness to the touch. The Homan sign is characterized by pain in the calf when the foot is passively or actively dorsiflexed. It's not a reliable test for a DVT, but it's a way you can have a patient at a positive Homan sign, meaning they need further investigation to figure out what's going on. If you're working with a patient who has these symptoms, you need to stop your treatment. You need to get the nurse. You need to let the nurse know. You need to talk to the physical therapist about what you're seeing. And the prognosis of a DVT depends on the extent of the condition and where it is. Of course, a thrombus formation, a DVT can result in death if the thrombus becomes dislodged, and then it becomes an embolism, and it goes either into the heart or the lungs or the brain. A CVA or a stroke is possible because of a DVT. So how they will diagnose a DVT is with a Doppler study, as well as like we were talking about with peripheral vascular disease, to see if there's any potential blockages. The patient will be put on bed rest. A compression bandage may be used. They would probably start the patient on some type of anticoagulant medication to prevent further blood clots, some type of a medication to also break up the clot. Let's see. The PT and the PTA are involved with ambulating and exercising patients early after surgery to reduce the risk of developing a DVT. The PTA should be careful to note any lower extremity pain, particularly in post-surgical patients, that seems unusual, and then immediately advise the supervising PT, nursing staff, etc. In most cases, it's not like a panic situation where you're going to like hit a code blue button, but you're definitely going to want to stop your therapy and have someone take a look at it and check it out before you continue your therapy. So a DVT is something that I guarantee you'll see a few times or more in your career. Okay, that is the end of this presentation. I hope you're still awake out there. I know it's about midnight here at my house, so I'm going to go to bed, and hopefully that was helpful. Let me know what you think. Talk to you soon. Bye.